Hi, Matthew Holt, and it is another THTV Spotlight. And we're going to dive in a bit to some of the tech that's been really exciting people around the whole world of AI and doctors using new tools to manage the exam room and a whole bunch of other stuff. And I have with me Shiv Rao. Shiv is the CEO of Abridge, which has been around a few years now and made some noise in the last few weeks, mostly because it was the inaugural PAL, which is kind of a weird thing to be of the Epic Partners and Pals program announced at the Epic general meeting a while back. Epic has migrated from having like the app orchard. I guess he used to be an Apple or something, and now you're a pal. I don't know. Who knows? Anyway, and Shiv is going to show us what the Abridge technology does. So, Shiv, thanks for coming on. Looking forward to hearing about this.
Thank you so much, Matthew. It's a privilege. Really
and
excited.
and also seeing, by the way, as well as seeing. So, full disclosure: when you guys were just getting going, I used the consumer version of Abridge, and it worked kind of okay, but it wasn't the greatest experience. And I think you were in those days aiming at consumers. Since then, you kind of really narrowed down on looking at going directly at the market to help physicians in the exam room use use the audio in order to create the note. And this has kind of been the dream forever. Obviously, for years, physicians have dictated dictaphones, and then they've had to look at transcripts done wherever. And many physicians have had notes. I have personally been in a couple of exam rooms where physicians have not only either taken the EMR notes themselves or had scribes come in and do it for them. And we know it's not a satisfactory process. So that's the world that you're working in. And there are a number of other folks obviously aiming at that, not least the large company called Nuance, which was purchased by an even bigger company called Microsoft. So before we start, and I really want to dive into the demo, just quickly tell me where you live in that world, what Abridge is trying to do.
Yeah, absolutely. Maybe I can kind of kick off with a really quick background on myself. So I'm the
Sure.
founder and CEO, but prior to this, I worked at a really large health system. And I worked on the innovation side of their portfolio at UPMC. I was in charge of the provider-facing side of what we were investing in, into startups, into large companies for R&D, but also what we were overseeing from an R&D perspective at Carnegie Mellon University with their AI department.
Sure.
And a lifetime ago, I went to Carnegie Mellon, but in the middle became a cardiologist. I still see patients. So at this point in time, once a month, I'll sign up for the shift nobody else wants. And it's a privilege for me because I get to stay close to the mission of the company. And I also get to dog food Abridge myself. I get to use the technology that we're building. And hopefully that's an advantage for us where we can build, measure, learn that much faster with real user feedback coming from clinicians, not just me in the company, but others who also continue to see patients. Now, it's interesting in terms of the journey of the company because we started in 2018. And I think when we started the company, we were fairly, I think we had a very strong idea of what we were working backwards from. And that's reflected even in terms of seed pitch decks that we had put in front of VCs for that first round that we raised in early 2019. We had this idea that healthcare is really all about conversations, and it's between professionals on one side of the room and patients on the other. It's happening via all sorts of modalities. We couldn't have predicted what would happen with telemedicine during the pandemic, but certainly we anticipated omni-channel being really important. The ability to actually service or serve conversations wherever they're happening between those two types of people. But then we had this idea that this thesis that healthcare is about people and they're having conversations, that this is really big. It's expansive because dialogue is really upstream of the diagnostics we order, the therapeutics we prescribe. It's upstream of coding and rev cycle. It's upstream of experiences, and ultimately it can be upstream of outcomes on the right time horizon. And so what we wanted to do was position like our offering as something that could serve all the different entities, all the different constituents in healthcare, starting with the end users. And where we started, because the barrier to entry and like the minimum viable threshold for something that's viable for a clinician like me to use is rather high, we started with the consumer side of the story. And it's still out there. The technology that you probably used in 2019 or 2018 when you checked us out is still out there. It has over 450,000 people using it. You can download it off the App Store. And it's kind of like transcription on steroids, on a little bit of like medical steroid, in that you can record a conversation as a patient with permission, and then you'll get a transcript of just the medical parts, not the part about the Barbie movie or the great restaurant you just went to. And it'll also layer in some health literacy related to the symptoms, diagnoses, procedures, and medications that you discussed with your clinician. And then it can nudge you in a week or two with reminders on your next steps. But as we were serving patients with that solution, we were all the while doing the R&D on the provider side. And so that's, I think, that moment that you're speaking to, that's all the rage right now. Over the last year and a half, we've been translating a lot of that R&D into a solution and really putting it in front of the enterprise. And now connecting the dots where not only can the enterprise serve their professionals, their doctors and their nurses with something that can unburden them from their clerical work, but we can also layer in that patient offering, the same patient offering you used, but it is different when it's kind of flowing from the clinical side.
Yeah. And I'd also point out that, in the world of AI and speech recognition and large language models, 4 years is a hell of a long time.
Long time.
Right? So you showed me offline a quick example. So do you want to just fire it up and show us how it actually works? That would give people a really good idea about where the state of the art is, because it's actually it's pretty impressive. So why don't you fire it up and I'll be a patient.
Yeah, absolutely. So I think we can kind of lead off with just a little bit of context. So healthcare conversations are different from monologue. Dialogue is very different, right? Because when I started seeing patients as a doctor over a decade ago, I was dictating a lot of the encounters I had with people or a lot of the procedures I did. I'd pick up a dictaphone and you learn how to dictate really efficiently. So I would say, 30-year-old male with a past medical history of diabetes and hypertension who presents with chest pain. Chest pain began 2 weeks ago. It's worsened by this, alleviated by this. They tried this and that, and now they also have associated symptoms of fevers and chills and nausea and vomiting. But I'm saying next line, next heading, past medical history, capital P, past medical history, colon, next line, dash, hypertension, next line, dash, diabetes. You have to dictate all of the detail that you need to bake into that artifact, that note. And there's a learning curve to become really good at dictation, to do that efficiently. And this is very different. This is conversation. This is dialogue between two parties. And so in the dictation world, I always chose English, obviously, as my language. In the dialogue world, you have to meet the patient where they are. And so that's where we do a lot of work on multilingual models. There are people at the University of Kansas Health System, for example, who are using Abridge with all Spanish conversations, and they're creating one English note on the other side. And there's any number of other English languages other languages beyond English that we can also serve.
Plenty of English languages too, by the way.
Yeah, that's you. That's
as you may know with our accent.
100%. So it's multilingual, but it's also omni-channel. So if we were integrated with Zoom right now, I'd just hit a button and then you'd start to create the English note. But let me show you the way I used it a few weeks ago when I was on call. This was the app that I'd walk from room to room to room with. And the first question I'd ask you if you were my patient is, hey, Matt, do you mind if I use this note-taking solution? It's just going to help me focus on you. I won't have to take a chicken scratch the whole time or have my back towards you. Every patient says yes to that idea. Cool. And then I just hit the record button. And if you don't mind, maybe we can just have a quick conversation. Okay, cool. So, hey, Matt, you're my patient. I heard you're having some chest pain. What's going on?
Yeah, I just felt, some tightness, some shortness of breath, and some tightness in my chest, and I felt a bit worried.
Okay, when did this all start?
Yesterday.
Okay, tell me a little bit more. Did it start when you were doing something active?
I was walking up a big flight of steps, so
I see.
It kicked off then.
Okay, how long did it take till you felt normal again?
Oh, probably about 20, 30 minutes before it kind of all went away. But I started it up again by just getting up and doing some movement motion around the house just today.
Okay. Did you notice any pounding in your chest or palpitations?
A little bit, yes. A little bit of lightheadedness as well.
Ah, okay. Did you pass out?
I did not, no. But
okay.
I felt I had to go sit down.
I see. Any radiation of that pain to your arm or to your jaw?
A little bit in the top left arm. A little bit.
Okay. All right. So, I'm looking at my medical record right now, and you have a history of diabetes and hypertension. And I bring that up because, this is chest pain, and obviously I'm a cardiologist. The first thing I think about is, could this be a heart attack? Could this be what we call unstable angina, which means that you could have blockages in your heart that we need to address immediately? So You have these risk factors for heart disease like diabetes, hypertension. Your great-great-great-grandfather had a history of heart disease too. So I think we should take this seriously. Come in this afternoon. Let's get an EKG and an echocardiogram, and also do some quick blood tests, like get a CBC and a basic metabolic panel and a troponin level. Those are studies that'll give us a sense of how much stress your body's under. Okay.
Okay.
All right. And then I'm a full service cardiologist. So I want to talk about your other problems really quick as well. Your diabetes is out of control. Your last hemoglobin A1C was through the roof. It was like 1 billion in January. So I'm curious, are you taking your metformin every day?
Well, sometimes I take it when I remember, but it works really well on the chocolate cake, right? So if I take it with the chocolate cake, it's fine. Yeah.
I don't know about that. I think we're gonna have to get a nutritionist involved, because it's not just the cake. I saw you at McDonald's last week. You had like 20 Big Macs in front of you and a whole bunch of French fries. So I'm gonna ask our nutritionist to call you next week, start you on a low salt vegan diabetic diet. It's gonna be delicious. But also, I really need you to take metformin 500 milligrams twice a day. This is so important. And finally, it's time for us to talk about insulin. So our nurse is gonna call you on Friday. You've been reluctant in the past, but I think it's time for us to
Well,
just talk about insulin.
I
Okay.
hear insulin's very expensive, but is it getting cheaper now?
We'll find a way to make sure that you can afford the medications you need. So why don't we also get a social worker involved, and they'll call you next week, and we can make sure that you've got a supply of everything. Okay.
All right. Thank you, Dr. Rao.
Okay. Anything else you want to talk about?
I think that sounds like a lot for just one quick telehealth account.
All right. Awesome. So we just had a conversation, and now I can kind of talk through what happens. So the tech goes through every word that I said and you said, and it first makes a prediction. Well, what was this word? It needs to recognize the words. So if we talked about, if we talked in a different language, and if we interspersed English and Spanish, or English with Haitian Creole or Brazilian Portuguese or Hindi or whatever,
right,
the tech needs to be smart enough to be able to recognize all these different languages and kind of pull the words out. Once it pulls the words out, it then goes through all the exchanges, and it decides with the provider, the clinician for care communication, would the payer or the rev cycle agent or actor constituent, would they need this to be documented? And then finally, would the patient want this part of the conversation, where maybe I used a metaphor to describe heart failure. Maybe I talked about how the heart's like a house, and I went off for 20 minutes trying to teach you. Regardless of who the constituent is, what we do is abridge the conversation. So we're pulling out the bits that either any of those three constituents would want to see documented in whatever that system ends up being. So if we talked for 20 minutes about the Barbie movie or about politics, something controversial, you can rest assured as a clinician to build rapport however you see fit, knowing that the tech is going to pull out what needs to be in the record. Once it's pulled it out, it then classifies it. So when I think about classification challenges, my mind immediately goes to computer vision companies that are classifying a malignant nodule versus a benign nodule. In our case, we're classifying all the information against where it needs to go in the medical record. And as you know, it's not just the node, it's also orders. It could be the problem list. It could be any number of other workflows inside the chart that we need to classify information against. But then finally, we structure that data where it makes sense to structure it so that we can slot it into those right workflows, and we'll summarize it. We'll write a note. So let me share my screen so that we can go through the note, which was done in this case. I don't know, it took seconds, but here's our conversation. So we can go through this. And so for anyone who's not familiar, there's an archetypal way that all doctors, nurses, medical students write notes, not just in the United States, but really around the world. Right. There's a whole history behind that we can get into as well. But it's pulling out the information from our conversation, and it's writing those sections out for us in prose where it makes sense. But as I'll show you if there's time, we also structure data underneath everything. So here's the history of present illness. Here is the assessment and plan. And these are the two kind of problems that we spoke to. You can see it's problem-based. Yeah. And then there's these other sections as well.
Actually, if you go back up, you can see that it said, I think you said if you go to the text, you said my hemoglobin was 1 billion or something, or out of control, or there was, you made some joke comments about it.
Yeah.
And, the thing about McDonald's and whatever, and it says here that the hemoglobin is elevated, and the diet is contributing. The diet is contributing, right?
Yeah. Yeah, exactly. Like, let's look at this. So the patient presents with a recent onset of chest pain, tightness, shortness of breath, began yesterday while walking up a flight of stairs. It lasted for 20 to 30 minutes. Some light activity also brought it on. You also have some associated palpitations and lightheadedness, prompted them to sit down, didn't pass out, and some pain radiating to the left arm. Has a history of diabetes and hypertension. Your A1C was high, so it didn't believe my joke of 1 billion. You've been on metformin 500 twice a day, but you're not consistently taking it. And then you've been observed eating large amounts of fast food. So that's the McDonald's piece. And you've been reluctant to consider insulin in the past.
It was actually watching me this weekend. I went to have me burgers. Too many.
But citing concerns about the cost of the medication. Now, below in the assessment and plan, this is problem-based. This is the way primary care clinicians, internal medicine doctors, and even surgeons ideally document. Because what we're doing also is training our models to work backwards from like gold standard Medicare. What would Medicare want to see?
Yeah.
And so we're summarizing all the information that Medicare would want to see, that an auditor would want to see. And certainly it includes the next steps. So EKG, echo, CBC, BNP, troponin level. In the diabetes piece, A1C was high, nutritionist, start you on a low salt vegan diabetic diet, take your metformin, and we're going to talk about insulin. But let's just say we had that conversation and I, as a clinician, don't remember that piece where you cited concerns about cost. And what I can do, I can highlight any part of this note, a word, a phrase, an entire sentence. And what happens on the right is it shows us where the evidence came from. And I can even listen to it if I wanted to. So for example, did he say it really like subsides after 20 to 30 minutes? Again, like the evidence shows up. And not only do I see it, I could even listen to it.
How long did it take till you felt normal again?
Oh, probably about 20, 30 minutes before it kind of went away. But I started up.
Now that's relevant because we're pulling out, or we're retro-engineering, if you will, transparency into large models that don't inherently have them. And if you've ever played with ChatGPT, for example, you might not know the whatever percent of the time where it's hallucinating, where it's making something up that wasn't in the data. And so it's so important to build trust, we think, through transparency. So here, for example, we're pulling out a bunch of conditions and procedures, and you can similarly map. And I think when we had demoed before, we also showed you a whole bunch of stuff in relation to those back office workflows where we can similarly kind of give you that evidence. So that's the core tech. Matt, you mentioned the consumer app. I can demonstrate that as well.
We don't. I think that gives people a very strong idea. So two or three obvious sort of follow-ons from that.
Yeah.
What levels? I mean, that looked pretty damn good in terms of accuracy, right? It picked up a lot of stuff. If you go back and even pick up between the transcript and what I actually said, it was very, very close, right? And that's tough to do anyway. And then you're taking stuff out of there almost. You're abridging, but you're essentially taking the pertinent information out of there and structuring it almost straight away. So two questions about the workflow. One is, does it so take orders out of this, or do the orders have to be separately re-entered? If you say, okay, we're going to get you a social worker, at what point does that get automated and like in the workflow, a social worker shows up somehow, or does the clinician still have to do something? And then the second most important part is when the clinician checks the note, what's the sort of step between looking at this and then making it final and signing off?
Yeah, absolutely.
So the first question was orders, and the second is sign off.
Yeah. So a few weeks ago, when I used this myself in my own practice, I hit stop, I swivel my chair, and my note is there inside the medical record.
Right.
And it's sitting there. It's in all the right fields. It's not just one sort of unstructured sort of note, if you will. It's not like a copy and paste. It's all in its right place. And what a deeper integration with the medical record also affords is the ability to not just have the note in the right place, but exploit what we're also doing, which is structuring data, pulling out diagnoses, mapping to ontologies that then map to the medical record, entities and attributes for all the next steps. So if I'd prescribed to you metoprolol 25 milligrams twice a day, metoprolol would be an entity, and 25 milligrams would be an attribute, and twice a day would be another attribute. And that's what we can now integrate into the medical record in a deep way, wherein this is templated. But one important aspect of the solution, as we've envisioned it, is that, and as it's in practice, is that the clinician is always in the loop. We're not ever going to say that this note is done for you, as good as it might be, and as good as that demo looked, because we always want the clinician to sort of trust, verify, look at the note as if their intern created it for them. And they're very quickly sort of trusting and verifying. Maybe they're addending, maybe they need to do a quick literature search and see what the latest evidence is on something before they finalize or crystallize their opinion. But we want to make sure that clinician is in the loop, whether it's on the note, whether it's on orders, whether it's on the problem list, or any other aspect of the workflow.
But I mean, so now on to the second one, and I'll go back to the first one. So now you saw the note, you sign off. How accurate in practice have you been?
Yeah.
And how much effort from saying, yeah, click accept, as it were, is the typical encounter been?
Yeah, we're automating well over 90% of the note is being generated by the AI in our metrics. And then clinicians, interestingly, based on subspecialty, will make edits because specialties inform the style of the note, if you will. Like certain sections of the note are a little bit more art and they're stylistic, and you go through your training, your residency, and you learn that you're an oncologist and the onc history lives in the HPI, and this is the format that it adheres to, and it requires a deep integration with the EMR to be able to summarize that. Similarly, if you're a cardiologist, you're probably writing that history around the chest pain in the way that we just demoed. We're talking about the pain and then how long did it last? Does it radiate? What makes it better or worse? There's a certain style to breaking down any chief complaint that a patient might present with. So there's art here, and it's the art aspects, I'd say, where people might still need to edit based on who they are. That said, there's also a lot of science into what needs to be in the note. And of course, you want to work backwards from E&M guidelines. What are you going to get compensated for? What does Medicare need to see in a value-based care paradigm? And those are easier, obviously, for us to train our models against, knowing that there's like a strong kind of metric for gold standard.
So if you're taking almost all, but obviously leaving them of the work in terms of typing or however note taking or however it's been done before. Clearly, I've been in a situation where clinicians have written stuff down in hand and turned around and typed it later or at home at night or whatever, and you're taking a lot of that away. So that's great. Of the rest of the workflow, I mean, I know there's a lot more going on in Red Cycle and what else, but just for the clinician, how much are you? I mean, are they having to also place orders as well separately, or is that essentially coming out of this? Once they've signed off, is a lot of the stuff they said the social worker call, for example, that you put in there.
Yeah.
I mean, what would actually have to happen is that if they had within their EMR a way of alerting or ordering or tagging for a social worker, would that happen automatically, or would they have to do that separately?
That's what we're working on right now. That's exactly the workflows that get really exciting, that require you to be deeply integrated inside of the medical record. Right. So I think it's one thing to be able to like create a draft of a note, and there's a whole spectrum of quality on that. Sure. And there are some notes that you could probably just sort of put in front of a person and they're willing to make a lot of edits to. There are other notes that are going to be closer to what you need to see or what gold standard would be in the community, the medical community. And then there are other notes where there's another tier, I think, of note that we're really excited about, where we're also building trust into these notes, where there's transparency. You can see where the evidence came from, and it's that much better of an experience. Interestingly enough, like a quick side story, there was a clinician at Brown University recently who was using the technology and sent us a message afterwards saying that, hey, like he thinks the technology had actually pulled out a history of a hip replacement that never got discussed between the two parties. And of course, we love feedback. It's oxygen and it helps us improve the technology. But when we did a quick check on this on the back end, obviously, and in a privacy and security like informed way, what we saw was that this was discussed, and the clinician just hadn't heard that part of the conversation, because we're all fallible. We only capture so much of the conversation as it happens. And so building that trust where you can, as the clinician, highlight that part, the hip replacement, and see where it came from, and even potentially listen to your patient's voice when they share that with you, we think goes a long way in terms of helping build a product that's really enterprise grade. But the other aspect of enterprise grade is what you're talking to. It's those deep workflows, and that requires like a level of API access that I think to date hasn't really been out there.
So let's talk about that deep workflow, and let's just quickly go to the connection with Epic. So you were the first PAL. I think there's some other PALs now coming up. I don't think anyone at Epic had heard of Papa and their PALs, but that's a side issue. Epic's naming is always fun and games. What does that actually mean to you guys in terms of the integration? What does that mean to you as a company?
Yeah, it's a game changer for us, because it makes all of our dreams come true in terms of our ability to deliver the best possible experience to our clients. But a very significant first principle of this relationship is that it's almost as if we are in a lab. We're trying to figure out how to innovate. Where can we take this sort of technology together? And how can we make those cycles faster? And so whether it's in a workflow that we might not have previously imagined, this technology being able to sing and finding out how hard would it be to build that connection and then test it at one of our client sites, or if it's more in relation to an implementation that we need to get done at a specific site, and what are some ways that we can kind of fast track this or make this easier on the client. It just helps remove a lot of the friction around technologies like generative AI that we truly believe can be paradigm shifting here. The care delivery experience for people who are using this right now, and it's not presentation, this is in practice, but clinicians tell us that it just makes everything feel different. They feel more present, they feel more alert, they're listening more as opposed to sort of multitasking at the same time. And however long of a game this is going to be to demonstrate that outcome improvement, we think that that'll be the most profound thing that we can demonstrate with technologies, that it improve the care delivery experience for the patient.
And then what's the business relationship with Epic? I know the App Store had some there was some stuff there. There were some rules, regulations, shares that a lot of people weren't too happy about. I don't know how you're early in the PAL situation. And clearly there have been questions over the years for how this kind of stuff works. But what's the relationship with Epic on that front?
Yeah, it's a close relationship. It truly feels as if the L in PAL stands for lab, in the way that we kind of operate together right now. The idea, I think the overarching idea of the Partners in PALS program is probably best explained by someone at Epic, but my layperson's sort of idea, framework for what it means is that partners are more established companies in this space. So Press Ganey is a good example of a more established company in this space that kind of meets the criteria for being a partner, whereas PALs are earlier in their journeys, and certainly Abridge, as mature or well-financed as we might be, like we're a startup at the end of the day. We're not some company making billions of revenue every year. And so for us to build the trust and build a relationship with Epic to be one of the companies that they've chosen to go deep with is certainly an incredible privilege that we don't take for granted.
That's good. All right, real quick wrap. So it's been 5-ish years now that you've been working on this. You have a number of clients. You raised, I think, 25 million odd over that time period. You tell me if I got that wrong. Where are you in terms of number of clients, number of clinicians on the system, number of people working for Abridge? Just give me a sense of your scale at this stage.
Yeah, absolutely. We have thousands of clinicians using this across any number of specialties right now. Certainly, I'd say where the bulk of the focus, the demand has been, is primary care, internal medicine, family medicine, associated subspecialties. But there are any number of ENT clinicians and palliative care doctors and other types of clinicians who are also using it on a daily basis. Company is still, I mean, if you look us up on LinkedIn, you'll probably see 30 some employees. That said, if you look us up in a few days, it might look very different. We're definitely in this mode right now in 2023. And I've used this line over and over, and I feel a little bit cheesy using it again, but it does feel like a tornado, not like tailwinds.
Right.
There's just like so many pain points. As you know, we've talked about clinician burnout for how many years? And also, I think in 2023, I think it's hitting different, and there's budgets being dedicated to addressing this problem because we've just sort of pulled the rubber band as far as it can go before it snaps. And I think what we truly believe in, what we're seeing, is this kind of technology. It's never about technology. It's always about the people. And we do believe that this is a technology that can actually help people deliver healthcare in a way that makes them feel more human.
Well, that's a fantastic place to end. I've been talking with Shiv Rao. He is the CEO of Abridge. He's just demoed the rather exciting and uncannily accurate, if you ask me, Abridge tool, which is now helping clinicians. I say clinicians nationwide, and hopefully coming to a town near you, I guess, is the answer. All right, awesome. Shiv, thank you for your time today. Great chatting.
Thank you so much, Matthew. It's been a privilege.